All right, I think we'll go ahead and get started. Delighted to welcome Dr. Alice Emery. For those new on here, Alice was part of the original team that helped to establish fellowship programs here in Grand Rapids in hospice and palliative medicine. Consider her to be one of the valuable partners in this, has been teaching fellows for close to 15 years. So thank you for what you do, Alice. And we're going to enjoy her in a couple of weeks as well. But for today, we're going to learn about methadone.
So yes, hi, I'm Alice Emery, and I'm currently working for Hospice of Holland and Keystone Palliative Care. And now that we've gotten through the basics of pain medicine, I think with Dr. Mulder, we're going to go into methadone in a little more depth, because as palliative care physicians and fellows, you're going to need to know more than the average bear about methadone, and it's a little bit complicated. So I think a little extra time spent on it will be valuable. What you got? So the goals of this lecture, we're just going to talk about how to use methadone and how to understand its pharmacokinetics. So we're going to try and get you to be able to use methadone safely in hospice and palliative care patients. And for many of the people listening to this lecture, this is going to all be review material, but my real target audience is the fellows. And so hopefully you'll pick up a few tips, at least from the stories, if you already know all about methadone. So here's some questions, and I hope that these questions would stimulate you to think about what you don't know about methadone. And then at the end of the lecture, I hope we'll all know the answers. How long does it take to get to the maximum blood level when starting methadone? What does it look like if someone takes too much methadone? How can methadone be both short-acting and long-acting? Morphine converts to methadone at 4-to-1, 10-to-1, 20-to-1, or all of the above. Why do they use methadone to treat addiction? Why is methadone a superior long-acting at the end of life? What kind of pain patient would benefit from methadone? And what are the warnings? So methadone is a synthetic opioid. It was developed way back in 1937 in Germany. And those German chemists came over to the United States after World War II, and it was manufactured in the USA ever since 1947. The mechanism of action is same as the other opioids. It works mainly at the mu receptor. That's its number one effect, but it also has a delta receptor agonist effect, and it has an NMDA antagonist effect. And it has a special effect on norepinephrine and serotonin reuptake. It's an inhibitor like an antidepressant. This is a minor effect. Pharmacokinetics of methadone are not simple, and so we're going to go over them at length today so that you guys will really understand them, I hope, and be able to sort of predict what's going to happen. Overdose and drug interaction can be serious and fatal, so we need to know how this all works. The danger is mostly caused by lack of knowledge and training in the use of methadone. It has been used safely and effectively in methadone treatment programs for greater than 40 years with adequate training and follow-up. And it is legal for use in pain. A lot of times that comes up where people say, is it legal to prescribe it? Anybody can prescribe methadone, just a matter of using it for pain. It also is used in substance abuse programs. So what's different about methadone? Well, the side effects, the basic side effects are the same as the other opioids. There's respiratory depression, potential for bronchospasm, hypotension, there's sedation. It's a little bit less sedating, I think, at effective doses than some of the others like Emery or OxyContin. You can have hallucinations and twitching at high doses or high for that person. And then there's some things that are different. It may be less constipating, and it seems to have an extra effect on neuropathic pain. And there's some things that are definitely different. It prolongs the QT interval. So that increases your chance of arrhythmias. And there's less tolerance developed to long-term methadone than to the other opioids. And there are more drug interactions. So NMDA, I think most physicians now come right out of medical school understanding NMDA is a synthetic compound that marks out a subset of glutamate receptors in the CNS and in the spinal pain pathways that act as potentiators for the pain signals. So blockage of the NMDA prevents escalation of pain stimulus and helps damp it down. And that helps prevent the tolerance from developing over time. So to use methadone, we need to know how to initiate it. We need to know how to get the right dose, and then we need to know how to follow up. We need to know how to follow up when we've changed the dose, or if we've added other foods or medications that might affect the serum methadone level. And even if there's a change in metabolic activity, we need to know whether that's going to affect methadone. So talking a little bit about pharmacokinetics, the first dose of morphine is similar to a methadone. Similar to a, sorry, let me back up. The first dose of methadone is similar to a morphine dose. So if you would give 10 milligrams of oral morphine and 10 milligrams of oral methadone, you get about the same effect. It will last about 4 hours and it'll do about the same things.
Short acting.
It acts as a short acting with the first dose you give. It works within 15 to 30 minutes, just like oral morphine. But the metabolism is slow and it's variable from patient to patient. There aren't any active metabolites. It's lipid soluble and it's protein binding, and it enters the tissues and it builds up in the tissues over time. The half-life is variable from person to person between 10 and 75 hours. So there's a huge difference in what your steady state is going to end up with the same dose, but different people. So the half-life will be longer in older patients. You can use methadone despite renal or liver disease. So your dialysis patients, your cirrhosis patients, you can still use methadone. You just have to adjust the dose based on the effect. CHF actually is somewhat of a contraindication due to the potentiation of arrhythmias. In patients with structural heart disease, they're already prone to arrhythmias and they have a tendency to get hypokalemia. And you know this because all the time we're having to follow people's potassium, and then that makes you prone to arrhythmias too. So CHF is a little bit worrisome. We do use methadone with CHF in low doses, but it always makes you worry a little bit. The serum methadone level is the main indicator of how much pain control you're going to have from your methadone. So that's the driver of the metabolism and the removal, and that's also the active drug that's working on pain. But most of the active drug in the body is not in the blood, but in the body tissues. It's not doing anything. It's just sort of waiting there. The oral bioavailability after taking a dose is high. 60 to 80% of drug is absorbed. It's easily absorbed. So orally, sublingually, rectally, it comes in liquids, tablets, suppositories, and you can use it IM or IV, although the IV is 2 times stronger, and I don't think it's recommended. There really isn't any reason, I think, to use IV methadone. Methadone can be given to a comatose patient just as easily as to a patient who can swallow. So if you crush the methadone and sprinkle it into a person's mouth, it's absorbed wonderfully well. There's really no reason to use IV, because when you're titrating an IV pump, you feel like you're adjusting and then you're looking at the response. But whatever dose you're at is going to take up to a week to get to steady state. So using IV medications gives you a false sense that you're seeing the effect when you really aren't seeing the effect that you'll get when you're at steady state. So I don't recommend that. But also, I think, Dr. Mulder, you and I both have had experience using methadone topically.
Yes. Mm-hmm.
I first read about using methadone. There was an article, a PharmD had experimented using different vehicles, and he decided that cold cream was easily available and worked well. So he would crush a methadone tablet, put a spoonful of cold cream on top, and then that was a topical rub that you could put on your hands or wherever you needed it for pain. And I have used that for peripheral neuropathy that's painful, and that works really well because it gives you the majority of the dose is topically.
Yeah, the other thing that I've, again, experimenting when you know that would be a good drug for somebody. I had a patient once who was very sensitive to medications, but had really disabling migraines, and had been to the ER, and opioids were only of marginal value, but given she had some structural anomalies in the brain that we thought were contributing to this, so we thought that methadone might be a good option, but she really had a very, very difficult time tolerating any oral dose. So we compounded it, and she was getting the equivalent of 1 milligram. And we were just, again, I don't know if he was doing it in Eucerin or cold cream or something of that nature, but then just, measuring out the amount that she would put on there, rub that in, and it relieved and took away her headaches completely. So there is, because it's so lipophilic, it does absorb well, which is why you can give it so many ways. But yeah, we love topicals of any variety. So
of course, with topical application, you want to use a dose that you would give orally. So you're not going to give someone 20 milligrams to rub all over them if you're worried about what 20 milligrams would do if they had taken it orally.
You need to presume that they're going to absorb everything that you put on their skin.
Yes, and also that if their friend is putting it on them, they will be wearing gloves because they'll absorb it too. Okay, so another thing that I really love about methadone is the cost. The cost of methadone is about $10 a month or less. And I don't know if there's been an increase with inflation, but it's not a patented drug. It's way cheaper than long-acting morphine or than fentanyl patches or OxyContin long-acting. And if you have a patient who has no insurance coverage at all, or for some reason their insurance coverage is just not going to cover this one particular dispense, they can usually afford to pick up the methadone on their own. So there is metabolism of methadone, and just like about 50% of the drugs that we administer, the CYP3A4 is the primary enzyme that degrades methadone. And it's important because the other ones do a smaller amount of metabolism, but the number one there at the top is easily inhibited by co-administered medications. It also can be induced by certain medications. So that's a common way that drugs are metabolized, and it's going to be important in drug interactions. There's another thing, this transport pump, the P-glycoprotein efflux pump. It's a transmembrane pump that functions at the intestinal cell lining and the blood-brain barrier, controlling access to the cell interiors. And it removes medications or toxins like methadone from the cell. And there's a big variability in the expression of this gene. And that's a big source of variability in patient to patient on the serum methadone level and on the effect in the brain. And this is another thing that can be blocked by competitive inhibition by the same drugs that will block the cytochrome enzyme. So inducers are drugs that induce those enzymes that would remove methadone. And these effects can happen like over a week or so, a week or two of co-administration. An example of that would be if you're on a steady methadone dose, but you added Decadron. So if you add Decadron and you're on that for a week, that might actually induce increased numbers of metabolizing enzymes. And then inhibitors of methadone metabolism can cause a rise in the methadone levels, and you can even see an unexpected sensitivity to methadone. I had a patient who was on hospice for lung cancer, and he was a big, strong guy, very tough. And all of a sudden he was getting sleepy and he was getting twitchy and he was even starting to hallucinate a little bit. And we're like, what's going on? What drug interactions are happening? But what we found out was that he had started drinking grapefruit juice, a big glass every day at breakfast. And that actually inhibited the cytochrome 3A4 and caused his methadone levels to about double probably. Okay. So another thing that you need to know about methadone, which is like the number one most important side effect, is that it increases the QT interval. So adverse effects do not occur in very many patients. We don't see this very often, but we know it's a risk. And usually any time you have a patient who's had an arrhythmia on methadone, they have been on high doses, like 100 milligrams a day or more. And we don't use that high of a dose very often. And when we do, we need to, have it trigger our thought process that we need to check that QT interval. When you start to get up into the 40 milligrams a day range, you probably should be getting EKGs. For palliative care patients, we generally recommend checking an EKG before starting methadone for just everybody. Especially nowadays with so many medications on board on the average hospital patient. If you're thinking of starting methadone, checking an EKG certainly doesn't hurt. And for palliative care patients with some long prognosis ahead of them, it's really essential and recommended. The QTC, the guidelines now say that a reasonable cutoff for the baseline EKG before you start methadone is 450 milliseconds. That's QTC. And then if you do start someone on it and they have good results and you're going to continue it, you probably should check an EKG every year. And also at the beginning of using methadone, you should mention that there's a risk of arrhythmia and a risk of drug-drug interactions, along with the usual opioid risk discussion. Like many of the medications we use, the sedative effects can be additive. For example, if you have a patient who's already on Ativan, morphine, Neurontin, and Remeron, can they have methadone too? Well, if you check their EKG and their QTC is okay, then there isn't really any absolute reason not to. It's just a matter of, following the response. You always have to give people those warnings about sedative drugs, the driving and the alcohol and things, but you just have to go with what the response is. So with the drug interactions, the general principle is to check with your pharmacist or your interaction program when starting methadone or when adding a med to a patient who is on methadone. So if you can choose a safer drug, if you can say this drug prolongs the QT interval, but a similar drug does not, then try to pick the one that doesn't. If you're expecting that the methadone level may go up when you start, like say, nystatin or something, some people say you should try to decrease the methadone for that week while you're on the nystatin, but other people say just wait and see what the response is. So no one knows really what you should do, but you should be aware. In addition to all this, the patient might not even adhere to the regimen. They might add illicit substances, foods, meds, other things from other doctors, and they can increase or stop their meds unexpectedly. So we need to educate the patient, the nurses, the caregivers about what are the signs of rising serum methadone level or falling serum methadone level so that everybody can be aware. So what does it look like if you have too much methadone, rising serum methadone level? The patient will be sleeping more. They'll be sleeping too much. They might sleep, just take a couple extra naps, and you think, well, that's good because they've been, up all night with this pain, and it's okay to catch up. But they might start sleeping through lunch or sleeping through breakfast and lunch, and well, okay, that's not good. That's a little too much. And with MS Contin, if you're starting on a steady regimen of MS Contin, you might say to them, well, everybody is sleepy a little bit at the beginning, but you'll get used to it and it'll be okay. With methadone, you should not say that, because if you're sleepy on day 1, 2, and 3, what's going to happen on day 4, 5, and 6 when the methadone level continues to rise? So a person who's over sedated with methadone will have a lower respiratory rate. The respiratory rate won't be 26 or 30. It might be 12 or 10. They won't have a lot of pain complaints. They won't be taking tons of Dilaudid or Norco because the methadone will be taking care of that. And if you let them go, they will progress to a deeper and deeper coma, more and more sleep, and myoclonic jerks, hallucinations, and death. So we need to catch the beginning of methadone overdose syndrome before it gets to be fatal, dangerous, that sort of thing. You have too little methadone. So if your methadone levels drop, people will go into the usual opioid overdose or opioid withdrawal symptoms. So like the flu with insomnia, you get shakiness, tremors, you feel flushed, nauseated. A lot of times it's vomiting and diarrhea as the primary complaint. The patient's family will say, yeah, she threw up and she was having diarrhea, so we thought she had the flu. They'll be painful, restless, have trouble sleeping, and that's just opioid withdrawal syndrome. So sometimes, even though they already are continuing on Norco or something, they'll still have some symptoms when they decrease the methadone. So who should we give methadone to? First of all, we want pain that's more chronic than acute. We're not going to give it to somebody who's just about to get a celiac plexus block or who has who's post-op and expected to recover from the pain in 3 or 4 days. So we want someone with a chronic pain and a stable patient. We don't want a patient who's in their last 1 week of life because it takes that long to titrate up to steady state. So we'd like to start methadone earlier in the course of a hospice patient so that we have that control and we're not trying to start it right at the last minute. And we need to consider the risks and contraindications for our methadone patients. And we don't give it along with antiviral HIV drugs, and we don't give it to people with a whole lot of cardiac disease. Renal disease and liver disease are okay, as I mentioned before. Okay, so just a little more about pharmacokinetics for the more visual people. Here's a graph, Roxanol on the top or morphine on the top and methadone on the bottom. So we're initiating the use of the medication. You can see on the top left red graph, if you were using Roxanol dosed every 3 hours, it goes up. This is the blood levels go up and down with time. So if you're dosing it frequently, you see the blood levels go up and down, but the baseline doesn't change. MS Contin also, the blood levels are going up and down more slowly, but the baseline doesn't change. But with methadone, no matter how you're dosing it, the baseline amount of drug in your system is going to start going up. The serum methadone levels will drop off after each dose, but you'll see that as you go on, the baseline starts to rise. So as you begin dosing methadone, you're steadily giving it, you'll see that the total body methadone levels go up and even the serum levels go up. So whether you're dosing it every 12 hours or every 8 hours, those the total body methadone will go up. There'll be drops in between. The serum level will drop, but the total body level will continue to rise. So just like when you're starting a Duragesic patch and it takes a couple days to get up to a steady state, it's the same with methadone. It just takes longer. You will at first get an effect, but it will take up to 5 to 7 days to get up to a steady state. And every time you dose it, it will drop off, but it will continue to rise in the total body amount. And sometimes you can kind of see that the first few days, you'll get a good effect right after you give the dose, but then in between the doses, it won't be adequate. So you'll need to have your PRN medication in there. And then if you see that the Duragesic, if these orange arrows are showing what blood level is needed to provide pain control, the Duragesic will get you to a steady pain control sooner than methadone does. And when you take the Duragesic patch off, or if you stop administering the methadone, the blood levels will come down. Just a typical curve. They'll come down slower with the methadone than they do with the Duragesic. But this is something that people get confused about. They feel like methadone may just all of a sudden increase on you after you stop it, but it doesn't do that. If you stop giving it, the total body levels will come down. Now, the way people get that idea is by giving Narcan or doing something like dialysis or plasmapheresis, where you're removing the methadone from the serum. So if you remove the methadone from the serum, or you remove the effect by giving Narcan, you still will have increase of methadone in the serum again, because it will keep eluting out from the body. And so after you get rid of the effect, you will have an effect come back again in 4 to 6 hours. And that's why people get this strange feeling that methadone can just increase on you. Okay, so I want to talk a little bit about opioid rotation. This tends to be where we use methadone a lot, where someone is already on an opioid regimen that includes a long-acting and short-acting medications, but they're getting toxic symptoms like sedation or hallucinations or twitching or itching. And when I say twitching, I mean like myoclonic jerks, something that's directly linked to the opioids that they're on. And so rotating to a different opioid is really helpful. Or if you have a long-term pain patient, just rotating from one long-acting to another long-acting is worth doing every so often because you don't have complete cross tolerance. So you'll get a little more bang for your buck. And you also don't have the same side effects. So you'll get an improvement in pain control. If you feel like you're up to the max so that you can go with your MS-Contin or your OxyContin or your fentanyl patch, switching to methadone will probably have a beneficial effect. But you have to convert. You have to do the math and figure out how much methadone to put them on. And that's a little bit tricky because there are differences in individual metabolic robustness, and there are pain receptor heterogeneity differences, and there are patient compliance factors and drug interactions and absorption interactions. There's a lot of things to think about when you're doing opioid conversion. So like most opioid conversions, we start with calculating a daily oral morphine dose, and then we use one of these conversion factors to figure out how much daily oral methadone we're going to give. So unfortunately, it's not just a single factor because it's a curve. It's not a straight line. And there are, I don't know, 20 or 30 different of these tables. I try to make it as simple as possible, but basically, if you're on a lower dose of morphine equivalents, you'll need more of the methadone than if you're on a higher dose. And that's a little bit of a strange thing because there's a curve like this. So each one of those factors is like one of those little orange arrows, and it's giving you a straight line that approximates this curve. So if you say, well, if they're less than 100, using the bottom part, less than 100, we convert 4 to 1. Between 100 and 500, we convert 10 to 1, and then over 500 milligrams a day of morphine, we convert 20 to 1. That would give you a general idea. But the funny thing is that it almost always comes out between 2.5 and 10 every 8 hours. It's almost like you could just say a small, medium, or large dose and wing it.
Yeah, I saw a graph once very, very early, 25 years ago, which was kind of when I started getting more deep into methadone prescribing. And it amused me because it had 6 different doses on the left side, and on the right side, it was exactly the same for everyone. So it was kind of like, why mess with?
Why do we need to know all this? Yeah.
You just put them on the low dose and titrate to effect. And so
Yeah.
It's complicated, but I don't know that we need to make it as complicated as it really is.
I agree. So
Start low and go slow, and
right. So, but sometimes you think start low means 5 milligrams 3 times a day, but for the low end, that's really maybe too much for some people.
Right.
So yeah, it's good to start with these, but you'll get the hang of it as you go. So for patient taking oral narcotics in a short-acting form and you're ready to add a long-acting medication, you can use methadone as your first long-acting medication as well. So you can use it either Q8 or Q12, and you can allow them to continue to use their breakthrough short-acting medication. I feel like this is very helpful when you have a patient who's starting methadone, because if you're starting them on, say, 5 milligrams Q12, and their pain is uncontrolled, and you want them to wait 7 days for their pain to be controlled, it's not very popular with the patients. And I've had a lot of patients tell me, oh, I tried methadone, it was awful, it did nothing, and I couldn't stand it, and I never want to take it again. It's because they didn't give them good pain control while they were slowly titrating the methadone upwards. So we want to make sure they have a good breakthrough med. So I calculate the total amount they're using, including the long-acting and short-acting, or all the short-acting, and then replace all of that with methadone, and then let them have a a PRN med that we know will work. Okay, so now we're gonna do cases. How are we doing on time?
Doing great.
Okay, so we're halfway through. So here's a 60-year-old man. He's on hospice. He's got lung cancer and he's on MS Contin, 90 milligrams every 8 hours. And he's really been taking his short-acting morphine quite a bit. He's taking 40 milligrams every 3 or 4 hours PRN. The last few days, he's taken it 5 times a day. His pain, he says it's controlled, but his family says he's sleepy and twitching. His total daily opioid is 470 milligrams. So who would like to help figure out how to convert this guy to methadone?
Anybody can speak up. Simple math. Don't be shy.
Well, so if you looked at his total,
by 10.
total daily, divide by 10, 47
Mhm.
milligrams of methadone.
And if you wanted to give the 47 in 3 equal doses,
Yeah, you do 15,
15 Q8,
8.
yeah,
But would we be worried that he's? Do you want to?
he's already kind of
That
high.
he's already.
He's already, yeah, so I think it would be safer to cut it back a little bit and go with 10 Q8, yeah.
Okay,
And then have something.
yeah, we've talked about the concept, but it's really always worthwhile reaffirming. Adjusting your conversion for cross tolerance.
But that is what these conversions are trying to tell you. Is
Yes.
What is the cross tolerance?
Yeah.
What are you gonna end up with? Yeah.
So,
So, but if the person's already kind of on the high end and you're not sure what you're gonna get with the methadone, it certainly doesn't cut it down a little bit. I mean, he has his morphine that he can take PRN, so it should be okay. So we divide it by 10, we get 47, 3 equal doses, 15. And you provide the teaching to the patient and the family, and then you try to reassess at 3 days and 5 days if possible. Patients do not like it if you've let them go a whole week and they're sleeping through all their meals before you touch base with them again. They probably will already have dismed and say, we're not gonna take that anymore, because that made them completely groggy. So you need to touch base with them at 3 days and 5 days if possible. So it's easy on a hospice patient to say to the nurse, I need somebody to be touching base with the patient and caregiver to make sure they're not too sleepy. And if they say they're sleepy, but their pain's completely controlled on day 1 and 2, I'm a little worried because we know their blood levels are going to keep going up. So I'm not going to tell them, oh, don't worry, you'll get used to it. Like they say with MS Contin. I'm going to say, we might need to go to Q12 instead of Q8, because I think you're already getting a lot of good effect from that. All right, so here's another case, an 89-year-old woman in assisted living with pain from spinal stenosis and arthritis. She's got overall fragile health. She's not able to tolerate a lot. She's taking Motrin and Tylenol, and she takes a half of a tramadol 25 every 6 hours. So full doses of tramadol or hydrocodone caused her to be groggy. 100 milligrams of gabapentin was too much. So can we use methadone in a patient like this, and what dose? Any ideas? Well, I'll tell you first,
wait, let's just
give them more time.
we have 50 people on this call. So,
Can't tolerate even tramadol, right?
Yeah, I worry about that.
Giving her anything, right?
Yeah.
Yeah, so the thing is that methadone is slightly different because it's kind of a mostly continuous. It is easier to tolerate than say Norco or something if you give it in small enough doses. One of the problems with long-acting medications is they mostly have a bottom dose that is pretty high, like the smallest fentanyl patch and the smallest MS Contin are too high for some people. And the smallest methadone tablet is 5 milligrams. So the lowest you can really get is 2.5 milligrams. But for patients like this, we can get the liquid. There's a liquid methadone. There are a lot of different formulas of liquid, but the liquid methadone you need is 1 milligram per ml. For some reason, they call it 5 milligrams per 5 ml, which is a confusing name because a lot of people think it's 5 milligrams per ml, but it's not. It's 5 milligrams per 5 ml. So that's 1 to 1. So you can give half a cc or half a milliliter, that's half a milligram, and do that twice a day. So for this lady, half a milligram twice a day might be just smooth everything out and make it so she's doing a lot better. And we have used that a lot in elderly patients. I've seen it where even going up to 1 milligram twice a day was too much for the person who was doing okay on 0.5 milligram twice a day.
I would just as a kind of as a footnote to that, that I've seen some docs who have very successfully used that ultra low dose methadone in nursing homes with patients that are, for example, are having a lot of pain with cares or with movement or the types of things which can plague these folks every day. They're going to be provided some element of dressing change or physical therapy or something of that sort, which is painful for them, and that just this really a microdose of methadone can make life easy for them, and also as an adjuvant. And so just it's really good to keep that in the back of your mind, the potential benefits of the small dose.
Yeah, and there have been some studies of just adding low dose methadone to cancer patients without changing anything else, like 5 milligrams once a day to lung cancer patients or things like that. And it does help. It just smooths things out and makes people more comfortable. Okay, so here's one I'm gonna need input from you guys on. Your facility patient has had an error. An 86-year-old man who's on hospice with prostate cancer and he's on methadone. His pain has been controlled with 1 milligram twice a day. And he's been doing very good with this low dose because he's an elderly guy. But at 8 a.m., he was accidentally given 5 milligrams instead of 1 milligram. And now it's 12 noon. Okay, they just discovered it. What do you need to know? What should you do?
Say, how's he doing right now?
So that's a good question. How's he doing right now? He's sitting in the lunchroom, he's chatting with his friends and eating lunch.
Skip subsequent doses.
So you think maybe we might skip a dose?
Skip the next dose.
Okay, but has he absorbed it all already?
No.
Why not? You absorb it really fast, right? 60 to 80% immediately absorb. It absorbs really quickly.
So the serum level would be.
Serum level's already peaked. It's already like 4 hours. It's already coming down. So he's already,
Half-life.
but the half-life of that particular dose, it will raise the baseline serum level just a smidge, right?
Yeah.
But he's already on the high end right now and coming down, and he's doing fine, right? So he doesn't need anything done particularly.
So you don't have.
He's okay. You don't even have to hold the dose. You could just say, how is he doing? He's fine. That's great. Because he's already absorbed it. He's already had the effect. He's coming down off of that effect already, and he's been fine the whole time. So apparently it didn't make that much of a problem.
The other thing that I think is important, and this is just overall for opioids, we understand that when someone has been on chronic stable doses of opioids, they develop a pretty good level of tolerance to that. I had it was a medical error in a hospital. I had seen the patient for a consultation in the hospital. They did not have a functioning GI tract. So it started, this is 15 years ago, on IV methadone. Got him controlled at about 2.5 milligrams.
So you could have used sublingual.
We could have, yeah.
But they didn't know that
But
back then.
yeah, so we did IV, and he was well controlled on that. Lived in a rural community. He was discharged from the hospital on that. Went to the local critical care access hospital near his home in this rural county, and they were going to keep him on the same thing. I get a call a day later wondering about the IV methadone because he was sleeping and they was having difficult arousing. Kind of went through all this. Is it really a drug, or is it sepsis or something else? Well, they had made a 10-fold error in the concentration. So he was getting 25 milligrams an hour of IV methadone.
Wow.
And so I was surprised he was still alive.
Yeah.
And I said, well, I would stop that.
Put that on hold.
Let's clear the system. And he did fine. But the point is that it really surprised me how well he tolerated that.
Yeah.
And so I think that a single dose error on this is, I think that the facility needs to get their act together in terms
Yeah.
of how they're managing
Yeah,
What
their drugs, but
caused the error?
yeah, but.
right,
in
but it
terms of
didn't
the
look like it hurt him.
Yeah.
So I had a patient where this happened and they called the attending for the nursing home and the nursing home attending said, give Narcan. So they gave our patient a big slug of Narcan. He went into a huge pain crisis and had a heart attack. And I was like, don't do that to our patients. Whenever you give Narcan, just give a little bit, a little bit, little bit. Don't just give them a big slug and see what happens. But anyway, he didn't need it and that wasn't good. So I want you guys to kind of know that it absorbs rapidly. You can see the effect pretty quickly. And then most of the time, or a lot of the time, it's not as potent in a single dose as you think it would be. Okay, here's another good case. The patient has taken almost a whole bottle of pills. He was taking 5 milligrams twice a day. He was on hospice for lung cancer and has recently expressed depressed feelings. Now the social worker found him with an apparent overdose. He took 16 pills of 5 milligram methadone less than 1 hour ago. What do you need to know? What are your concerns? What should we do? So this is a different scenario, right?
How is he doing?
This guy gets Narcan.
So how he's doing is that he's asleep and you can't wake him up. There is this picture right there. He's not waking up. His respiratory rate is low and he's snoring. So
Probably have to get dark. I agree.
Well, if it was less than an hour ago, could they even like pump his stomach?
right, so that's the question. I mean, less than an hour ago, he might still have some pill fragments and stuff in there. And you know, it may not all be gone. You may be able to give him charcoal or pump his stomach or something. And
put a patient on hospice through all of that.
right.
Yeah.
Right, so, yeah, it depends on the scenario, but probably, he's taken what may be a fatal dose there. And, I would say in general, you would think, let's send him to the hospital, or let's call EMS and see if they'll just take him to the ER for the afternoon and maybe he can come home again later. But you're probably gonna have to give a dose of Narcan now. And then you're probably gonna have to keep giving a couple doses of Narcan throughout the day. Sometimes they put people on a Narcan infusion or drip, especially if they were on a steady amount of methadone that got to be too high. So he still hasn't reached the peak effect that he's going to get from the methadone dose.
And if he survives this event, your pain management moving forward with.
I'll just put him back on the same.
Maybe presuming as a potentially purposeful.
Right, so he needs to
Yeah.
go through the usual thing that you would do if someone was threatening suicide. We might have to change him to a fentanyl patch or something that's easier to monitor, or we may have to give him smaller amounts to have in the home. We may have to have a caregiver take over giving him his pills rather than him taking them. There's a lot of ways that hospice can manage someone who they think might be suicidal. Mostly it's talking to people and finding out what they really were thinking and why and that sort of thing. Sometimes it has to do with being a burden on the family or something like that. Okay. Here's another case. This is a lady with esophageal cancer and she's on a Duragesic patch. She complains of pain that's with swallowing and new or worsening burning pain and numbness around the ribs on the left side of the chest. Her pain control is inadequate, using 20 milligrams of Roxanol every 2 hours, and she's had 8 doses in the last 24 hours, and she's rating her pain at an 8. So what can we say about this patient? There's a lot that you could say about this case.
Looks like she's got neuropathic.
I was gonna say this.
So it sounds neuropathic, doesn't it? The burning and around the rib like that. What do you think about that Duragesic patch?
Well, I'd want to know too, like, is she cachectic? Is she absorbing the patch? Is she absorbing the medication through the patch?
Okay, yeah. So I would ask about the patch adherence. Sometimes they say, oh yeah, she sweats so much, but we just keep sticking it back on, you know, and that's not going to give you a good, reliable, steady amount of fentanyl that way. And you think about the adipose tissue reservoir that you need to have under the patch. So if a person is really cachectic and they don't have a 1/4 inch of fat under that patch, it's not going to be reliable in how it dispenses the medication. So the new pain does have a neuropathic quality, so we might want to add some adjuvants if she isn't already on gabapentin or some other adjuvants for nerve pain. And methadone may do better than a fentanyl patch for the neuropathic component of the pain. I feel like for chronic neuropathic pain, fentanyl patches are not that good, really. So how do we convert a patch to methadone? Well, first of all, we use a rough estimate for converting a patch to oral morphine equivalents of 2 to 1. So, or 1 to 2. 200 micrograms of duragesic would convert to 400 milligrams of morphine a day.
And just the numbers work, but just to keep in mind that 200 microgram means 200 micrograms per hour.
Per hour.
Being dispensed through the patch. So it's not an exact, it doesn't mean that 200 micrograms of fentanyl equals 400 milligrams of morphine.
No,
It just means that at 200 micrograms an hour,
patch.
the daily, the daily total duragesic dose equals about 400 milligrams equivalent of morphine. The math works easily, just because you can run that through in your head if you're doing these conversions on the fly.
Yes,
Either way, if you've got someone on, the morphine, they're on, 200 milligrams of the total morphine a day, and you need to put them on a patch, just divide by 2, and that's your patch strength. So.
So if we add the breakthrough dose that she's using, the total daily morphine equivalence is 560. So it's under 600, so we convert 10 to 1, or you could say, well, let's convert 15 to 1. And you come out around 56 milligrams of methadone a day. So you could divide that, pretend it's 60 and divide it by 3 and give those doses, give that. But in most cases, you still might want to decrease a little bit, and that doesn't hurt anything. So you definitely can probably get better control for this person.
Here's the fun thing about this case is that this begins bringing the art of these conversions into play. It's not just math. Math is where you start.
Yeah.
And then you think about the fact, well, was she getting good absorption and adherence to the patch? So maybe
Right.
she wasn't getting that much.
Right.
On the other hand, she's at an 8, so
Yeah,
she may need
pretty-
some element of opioid titration if she was getting all the. So you have to really assess clinically and take a very, very close look at the patient, and then always err on the lower side because you can always go up.
Mhm. So we would let her still have her breakthrough pain medication.
Absolutely.
And we would take the patch, just take the patch off, put methadone on. There have been times where people have tried to taper down one long acting while the methadone is increasing. I find this too confusing for everyone. It's too confusing for families at home. It's too confusing for nurses in the hospital. You will get a call every shift asking, what dose do we give? Because if you're trying to taper down, even MS Cotton, if you go from 60 Q8 to 30 Q8 to 15 Q8, meanwhile, you're increasing the methadone, it's just too much for people. If you just stop the long acting and start methadone, that gives you the best chance to know what you're doing. Okay, so another case. This is an 80-year-old man, really elderly. He had metastatic melanoma with pain in the groin and the hip socket. He had severe pain. It was incompletely treated with Vicodin. He didn't like the Vicodin because it caused nausea. The family thought it had a bad effect on his mental status. Hospice team put him on a fentanyl infusion because that's what was available that week. And they got him comfortable at home, but the family still thought he was too sleepy and groggy. They didn't really like it. And they decided to transfer him to assisted living. Now, the facility did not take patients with any kind of pump. So we got a call from the house. Oops, we're transferring this guy, but we have to stop this fentanyl infusion. Can we immediately change it to something else? And what would it be? Of course, you could change it to a fentanyl patch, but the family doesn't feel like the fentanyl is working that well for him. He's on 75 micrograms per hour infusion. So how many morphine equivalents? How would we start him on methadone?
morphine equivalents.
So 150 morphine equivalents. Good.
Is the infusion the same as the transdermal?
We basically consider it the same. So 75 micrograms per hour infusion is the same as 75 micrograms per hour patch, which is nice and easy. So, and if you are giving someone in the hospital 75 micrograms per hour breakthrough, like dose, it's basically the same. So fentanyl is nice that way. So morphine equivalence, we say, is 150 milligrams per day. He can't have the pump, so what we needed rapid titration of the methadone. We needed to try and get that going. He did not have a PRN med that worked for him. So we went ahead and started 5 milligrams every 8 hours and 5 milligrams Q4 hours PRN, meaning in between those 8-hour doses, knowing that he was likely to have some periods where he wasn't getting adequate pain control in the beginning, we gave him the 5 milligram methadone as a PRN as well. And he was transferred to assisted living. He remained comfortable and he ended up staying on the 5 milligrams Q8 hours. But during the first few days, he also used the PRN. So this is another way of initiating methadone. And this has been used by some people. In fact, there were several different protocols that people used where people just took it PRN for a certain period of time and then they switched to a steady dose. In my case, with my experience, I'd like you to start with a steady dose that you think is going to work and then add some PRN if you need to the first few days and let the PRN drop off as the steady state is reached. So this is usually not too confusing in a facility because they have a strict differential between a scheduled dose and a PRN dose. It's a little more confusing for a family to do. You have to make sure they know, no, we're not just giving it every 4 hours no matter what. We're giving it every 8 hours no matter what. And then we're giving it every 4 hours if you need it in between. It's a little harder for families, but that's one way of getting going with methadone faster.
And the other thing is that, again, if this patient were going home, it requires telephonic follow-up.
Yes.
Every 3 to 5 days, you've got to call and talk with them if someone needs to make sure they're doing all right.
And I have had patients where they have severe pain, they're in the hospital. Like I had one guy who was a middle-aged guy with bladder cancer, a lot of pain, bone pain, liver, kidney pain. And they're like, well, he's discharging at 3 and here it's 1 o'clock and we want to start him on methadone. Like, well, gosh, I'd like to give him his first dose in the hospital, but we're not going to get, adequate pain control right away. So I gave him 10 milligrams right on the start, and then we're going to go with 5 milligrams Q8 after that. So you can give a slightly bigger dose at the beginning, like kind of front loading a little bit, but there isn't really any good studies about whether that's safe or not. So we don't do that very often. In this case, there are studies showing that this kind of a PRN regimen is safe and can be used to initiate methadone. All right, so this is the last case, I think. This is a 60-year-old palliative care patient. She's been on Percocet for chronic back pain and shoulder pain. Her prescription coverage is poor. She often finds herself having to pay for her own medication. Her overall health is declining. She's expected to have a short prognosis due to renal cancer. She recently has been taking up to 8 Percocet per day. So the Percocet has oxycodone 10 in it. So that's 80 of oxycodone a day. Do you think that she would benefit from adding methadone?
Yes.
Yeah, I mean,
Yes,
Yeah.
the answer is yes.
Yeah.
this is a methadone lecture, so.
Yeah, the answer is yes.
The answer is yes, she would do probably good with methadone, and I'd rather have her on methadone as her kidney failure, is progressing and probably her kidney functions varying. So what dose would we pick? She's under 100 milligrams a day of oxycodone. So if we were at 80 a day, you would divide it by what? 4? And then what would that give us? 20 3 times a day. That still sounds a little high, doesn't it?
Yeah.
23 times a day.
No, 20, 40,
A
60.
day.
20 a day. Okay, yeah, okay.
5.
555, yeah, 555 sounds good. So if we switch to, because she has the Percocet that's covering, but we don't want her to be taking 8 of those a day. So if we were to give her just 5Q12 or 5Q8, she'll probably get a good boost to the effect that she's getting. And the problem with taking something like Percocet or Norco, people want to take, oh, just let me take 10 a day of these, or let me take 20 a day of these. They wear off completely in just 4 to 6 hours. So, first thing in the morning when you wake up, your pain is there 100%. And so if you can take a long acting like methadone and just, bring the whole pain level down and then just use the breakthrough med for the peaks, it just works a heck of a lot better. All right, now we're back to these questions. Now, looking at these questions, we should have more answers, I think. How long does it take to get to the max blood levels when starting methadone? I think we now know 5 to 7 days. What if someone takes too much methadone? What happens? Well, it's rapidly absorbed, the effect is immediate, and you may need to do something serious about it based on their response. How can methadone be both short and long acting? Well, I think you understand it builds up in the body, in the tissues. Morphine converts to methadone at 4-to-1, 10-to-1, 21, or all of the above. All of the above. Why do they use methadone to treat addiction? I don't know if I discussed that, but it's nice and steady, and they can give it just once a day and prevent methadone opioid withdrawal. And why is methadone a superior long-acting at the end of life? Well, for one thing, you don't have to stop it. Wisconsin, when you stop swallowing, you can't take it anymore. Methadone, you can keep giving it, just sublingual, crush it. It's very easy. It stays in your system a long time if you accidentally miss a dose. So it's very good for end of life care. What kind of pain patient would benefit from methadone? I think we talked about that. Neuropathic, but also chronic pain and also severe pain. So people with the more severe pain syndromes that we have a hard time managing. And then what are the warnings to keep in mind? We talked about drug interactions, checking with a pharmacist, QTC, maybe checking an EKG, and remembering what to look for along the course of your therapy with the methadone. So hopefully that gives you some basics. I think methadone has some concerns, the complexity of it, the stigma of the addiction, the potential arrhythmias, but it also has a lot of benefits. And there are just so many benefits that I hope you'll all become comfortable using it, because many physicians are not comfortable. And if you guys are comfortable using it, you can bring that extra benefit to patients and end up happier patients.
Yay.
Yay, that's the end. Okay, so I would like to hear if there are any questions.
As far as like doing the 3 times daily or 2 times daily dosing, do you have a preference, or do you just sort of based on like what's going to be easiest for the patient?
So I prefer 3 times daily dosing when I'm increasing, because it gives them a chance to have 3 of the short results of the short acting effects. And then you can give a PRN in between pretty easily. But for steady state, twice a day is just as good, I think. Some patients start to want it every 6 hours, and there's nothing wrong with that. It just seems like, it's not necessary. You really can get the majority of patients comfortable with Q8 or Q12.
Go ahead, David.
If you're transitioning a patient to methadone due to intolerance of another opiate, are you using methadone as also the scheduled medication and the breakthrough medication? And then as far as the PRN breakthrough goes, then are we just using it as like a similar as one of those TID doses?
So if someone's intolerant to another opioid and you want to switch them completely over to methadone, you can use the methadone as a scheduled and PRN same dose. Yeah, so if you're using 5Q8, just use 5 as your breakthrough in between, or 10, you can use 10 as your breakthrough in between.
And then would there be any concern about the frequency of that PRN dosing then, or what would that be?
So the frequency, I would just try and get it in between when the 4-hour has worn off. The first 4 hours you'll get an immediate effect, but then when that wears off, that's when you might need a PRN. So I usually do it Q8 scheduled and Q4 PRN. And just most of the time they'll just use it the first few days, and then if you guessed your dose correctly, they might not need it anymore. If you didn't guess your dose correctly and they're still using 2 or 3 doses, then you can change your schedule to accommodate that.
I just want one little pearl on methadone that I picked up a number of years ago that I've used. You mentioned that it comes in liquid forms in different concentrations.
Yes.
One of the really perplexing things that we face in both the hospice and in the palliative side, especially patients with cancer, those that have mouth sores, with a lot of mucositis and ulcerative changes there. And after trying a lot of different things over the years, what I found is that using the concentrated morphine, I used the 1-to-1 also, just a teaspoon
Methadone?
methadone, liquid, the liquid concentrate. And if they kind of swish and gargle that, that the topical effects there are very, very effective at relieving that. You got to be careful because we mentioned before, it's absorbed, okay? They need to probably swish and gargle for a minute or two, which sounds pretty short, but I would encourage you to see how long you can swish and gargle before you got to spit it out. If they have chronic systemic pain, they can swallow it, but then they're limiting how many times a day they can do that. If they really don't have systemic pain and it's just a localized pain, they can swish it for those couple of minutes and then spit it out, which then gives them the opportunity to use it more often. But the topical effect of that, those are very, very difficult pains to treat. We use a lot of the BMX. We use a lot of
For esophageal pain.
viscous lidocaine, which numbs up everything. And so the liquid methadone may have some utility there.
Probably the lower concentration liquids are also good for that because
Exactly.
the medication itself would be
Well,
going
and
to the
then
place.
you have a teaspoon that you can swish around. If you do it more concentrated than that, you don't have much volume to swish around.
right.
So, all right. Well, thanks, Alice. Great as
Thank you.
always. We really
Thank you.
appreciate you
Thank
doing
for
this.
having me.